All right. So welcome to our first tutorials on GMDC internal medicine. Internal medicine. All right. Patient P reported to your facility with fever, severe headache, no child rigidity, nausea, and vomiting. In his history, he went to the northern region a week ago. Prior to presentation, he had a tonic-clonic seizure. So we are talking to what, or we are referring to a person with fever, severe headache, rigidity or neck stiffness, nausea, and vomiting. And he has a history of traveling to the northern region of Ghana. Ago. Of course, talking about Ghana. Now, he also had what? Tonic-clonic seizure. So you ask yourself, what disease or what diseases can cause someone to have fever, headache, in other words, to have meningism. These are signs of meningism. Meningism. So that's what we're going to be looking at in this question. So anything that comes to your mind that you think can lead to meningism, please write it down. Or that is what the question is talking about. All right. So now let's begin. What is the likely diagnosis? Definitely you are looking at what? Meningitis, especially with a history or with a travel history of what? Or to the northern region. To the northern region. So we're having what? Meningitis, and this is likely to be bacterial. And so therefore we can say our likely diagnosis is bacterial meningitis. Bacterial meningitis. So that should be what you should be looking at for. For diagnostic features of this condition. For diagnostic features. In other words, what features will help us know that indeed this person is having bacterial meningitis, or simply put, meningitis. One, you can talk about what? Neck stiffness. Neck stiffness or nochal rigidity. Neck stiffness. That's inability to flex the neck forward passively due to an increased neck muscle tone and stiffness. We can also talk about Kerner's sign. Kerner's sign. And this is assessed with the person lying in the supine position with the hip and the knee flexed to 90 degrees. Now, in a person with a positive Kerner's sign, pain limits passive extension of the knee. Pain will limit the passive extension of the knee. And so therefore, if this is possible or if this is true, then it is a sign of meningism. It is a sign of meningism. The next point is the Brudzinski sign. Brudzinski sign. And a positive Brudzinski sign occurs when flexion of the neck causes involuntary flexion of the knee and the hip. I repeat, it is positive when flexion of the neck causes involuntary flexion of the knee and the hip. So when that is positive, then it is a sign of meningism. And again, you can talk about photophobia. That is intolerance to bright light. Photophobia. You can also talk about phonophobia. Phonophobia. That is intolerance to loud noise. Intolerance to loud noise. You can also talk about intoxication syndrome. An example of intoxication syndrome is the headache, the fever, the nausea, and vomiting. All these are together, we call them intoxication syndrome. Intoxication syndrome. So again, what are your diagnostic features? Neck stiffness, Kerner's sign, Brudzinski sign, photophobia, phonophobia. Then, of course, you can talk about intoxication syndrome. Intoxication syndrome. What likely organisms may be involved? So, if we are looking at bacterial meningitis, due to the history of this person, what organisms could be the causative agent? Of course, you can be thinking of what? Neisseria meningitis. Neisseria. Then you can talk about what? Streptococcus pneumonia. Streptococcus pneumonia. Then you can talk about Haemophilus influenza. Haemophilus influenza. So any of these will be correct. Now let's for differential diagnosis of meningism. For differential diagnosis of meningism. So what can cause the Brzezinski, the neck stiffness, the Kennex, photophobia, phonophobia? What can cause it? These are what? Meningism. So what are the differentials? So you can be looking at a brain abscess. You can be looking at brain neoplasms. You can be looking at delirium tremens. You can be looking at subarachnoid hemorrhage. You can be looking at encephalitis. And then febrile seizures. Febrile seizures. Febrile seizures. You can even talk about sepsis. When you have severe sepsis, it can also lead to meningism. So again, brain abscess, brain neoplasms, delirium tremens, subarachnoid hemorrhage, encephalitis, febrile seizures. Febrile seizure or febrile convulsion. All right. What investigation are you going to do in this patient? What are you going to do? So, of course, if for nothing at all, you can't forget your lumbar puncture, because lumbar puncture is one of the most diagnostic tool or investigation that we do for people suffering from meningitis. So you do what? Your lumbar puncture. Then, of course, you can do your full blood count. You can add blood culture and sensitivity, BUE creatinine, and then you can even add head CT scan. Head CT scan. So again, lumbar puncture, full blood count, blood culture and sensitivity, BUE and creatinine, head CT scan. These are the investigations you are going to do. So you mentioned them. How will you manage this patient? How are you going to manage this patient? Again, the question didn't say that this person is coming to you in an emergency case. So please forget about that protocol. Okay, go straight and treat the patient. So what are you going to do? So you're in your management, you are going to control the seizure or the convulsion. You are going to control it. So you're going to monitor and control the seizure. And to control the seizure, you need to give anticonvulsant. You can give anticonvulsant like the diazepams, the lorazepams, the phenytoin, and so on and so forth. You can give these drugs. So any anticonvulsant is okay for the treatment. Then you can look at for what? Or you can give IV antibiotics. IV antibiotics, especially ceftriaxone. Ceftriaxone. And of course, you can add ampicillin to it as well. Then you might want to control the fever or antipyretics. So you can give antipyretics like the paracetamol. Antipyretics. That is a control of fever. Antipyretics. So paracetamol can also be given. So these are what your management protocols or procedures. Again, seizure monitoring and control. And you can give anticonvulsant like the diazepams and co. You can give the appropriate IV antibiotic example, or especially ceftriaxone. And of course, you can also give ampicillin. Then you might want to give what? Antipyretics. Example, paracetamol. All right. Now, a middle-aged woman a middle-aged woman who is a known hypertensive with a history of non-compliance to medication presented with shortness of breath, which got worse on lying flat, so autopnea. She added that she gets tired easily with a productive cough of pinkish, frosty sputum. Pinkish, fruity, frothy sputum. BP on presentation is 220, 130. And sometimes you see this pinkish sort of sputum when the heart is more of edematic, or when there's a lot of fluid, or when there's pulmonary edema. It usually the patient end up coughing this kind of a sputum, or this characteristic kind of sputum. Yeah. So basically, that's what comes to mind. So here, you might be looking at something related to what? To the heart pathology, to the lungs pathology, and so on and so forth. Okay. So, and then you ask yourself, so what can cause pulmonary edema when it's a problem with the heart, isn't it? And again, they've told you that this person is hypertensive. So, like I've been saying, if they give you a question and they tell you the anamnesis, or they tell you a diagnosis that, or a chronic illness with this person, start looking out for what? The complication or the possible complications this might lead to. And to top it off, or to top it up, this person is even non-compliant to medication. So definitely, whatever that is happening here, it is the result of uncontrolled hypertension. Uncontrolled hypertension. All right. So guys, let's move on. What is the likely diagnosis? What is the likely diagnosis? So over here, you can look at for what? Acute left ventricular failure, secondary to severe uncontrolled hypertension. I repeat, acute left ventricular failure, secondary to severe uncontrolled hypertension. Yes, uncontrolled hypertension. Because now look at the presenting BP, 230, 130. This is extremely high. This is extremely high. And again, I was talking about the productive cough of this nature. Now, if the left heart is failing or has failed, what it means is that the blood inside the lungs are not going into the left side of the heart for it to be pumped out of the body. So everything is congested because the left heart is supposed to pump has failed or is failing. So as a result, everything starts accumulating congestion inside the lungs. And that is the reason why we are saying that the likely diagnosis here will be the acute left ventricular failure, secondary to uncontrolled hypertension. Uncontrolled hypertension. All right. What are the signs? What are the signs of this condition? Signs of this condition. So you have left, not you. I mean, your client is having acute left ventricular failure. What are the signs that you can be looking out for? So one of the signs include tachypnea. Tachypnea, that is what trying to hyperventilate, trying to breathe, isn't it? So you end up having what? Tachypnea. Then you can talk of what? Tachycardia. Tachycardia. Basal crepitation. Gallop rhythm. Displaced apex beat. Displaced apex beat. You can find cardiac murmur or third sound. Third sound. Cyanosis. Cyanosis. Rhonchi. Rhonchi. So these are the signs. You can just mention any one of them. Again, tachypnea, tachycardia, basal crepitation, gallop rhythm, displaced apex beat, cardiac murmur or the third sound, cyanosis, rhonchi. Rhonchi. You can add a whole lot to this, and you will be absolutely correct. All right. 4 risk factors of the condition. Risk factors of the condition. Yes, I know many people love to differentiate between modifiable risk factors and non-modifiable risk factors. When we say modifiable risk factors, they are things that you can actually change. The non-modifiable, they are things you cannot change. Just like when you are born with it. You are born with it, you can't change it. Your race, you can't change it. That is who you are. Your gender, that is who you are. You can't change your gender, isn't it? So these are some of the what? The, non-modifiable risk factors. You now have what? The modifiable risk factors, such as obesity, the diabetes, the alcohol abuse, the high blood pressure, coronary artery diseases, myocardial infarctions, valvular heart defect, congenital heart defect. Now, congenital heart defect, valvular heart defect, these are something that are what you are born with, isn't it? But still, we can find a way around them. Okay, so this one I'm just mentioning generally. So whether it's modifiable or non-modifiable is general, because the question is also general. Okay, question not specific on whether it is modifiable or non-modifiable. It just said give the risk factors, so we can give as many as we want. So keep writing them. Even medications such as NSAIDs can even be a risk factor for development of acute left ventricular failure. So again, high blood pressure, coronary artery disease, myocardial infarction, diabetes, obesity, alcohol abuse, congenital heart defect, valvular heart disease, certain medications like NSAIDs. You can be thinking about the gender, you can be thinking about the race, and so on and so forth. There are a lot. Just mention 4 and you are good to go. Now, list 3 diagnostic investigations you will do. So someone is having what? Acute left ventricular failure. What are some of the investigations you would like to do? Definitely, you would like to assess the heart, isn't it? So you do a chest X-ray. You do your ECG. You do the ECG to know the electrical activity of the heart. Then, one of the most important ones, echocardiogram. You need to do echocardiogram because that reveals the functionality of the valves. If the valves are in right standing, if they are good, or they're having problems. So you do your echocardiogram. All right. 4 supportive investigations. That means what other thing can support what you are thinking about. So of course, you can do your full blood count, your liver profile, your BU creatinine, your urinary, then the fasting blood sugar. So these are all what? Supportive. So basically, it helps us to identify the risk factors that we are having. For example, if someone is obese, definitely when you do a lipid profile, you might see high cholesterol level or a lot of what? Triglycerides. All of these things are all what? Supportive investigations. All right. How will you manage this patient? How are you going to manage this patient? Yes, of course, even though this person didn't come in the emergency room, but this question demands something like that because it's an emergency. It is an emergency case because you are having what? Difficulty to breathe. And when you lie down, there is a problem with breathing. That's autopnea. There's a problem with breathing. So we might want to what? Consider it as a factor in our management. So what are you going to manage this person, or how are you going to manage this person? So basically, you have to prop up the patient in a cardiac position, first of all. Prop up the patient in a cardiac position. Because when the person lies down flat, trust me, he can't breathe. He cannot breathe. So you have to put the person in a cardiac position. That's more or less like about 30 degrees from, the head area should be placed about 30 degrees from the surface or the flat surface. 30 degrees. Okay. Then, of course, you have to give intranasal oxygen. You have to give your intranasal oxygen. Then you have to give, now you want to reduce the BP. So you give what? Diuretics. You can give your diuretics. So all of these things is to control what? The BP. So you can give your diuretics, you can give your ACE inhibitors, You can give your beta blockers. All the kind of medications are used to control the BP. Then you might want to also manage other risk factors. You might want to manage other risk factors like the diabetes, like the dyslipidemia, and so on and so forth. Now, long-term prevention or long-term management, that is non-pharmacological means. What you want to do is you want to tell the person or advise the person on their lifestyle. So definitely lifestyle changes. So if the person is a smoker, you ask the person to quit or to stop smoking, to reduce the alcohol intake, to exercise regularly, to have a very good diet therapy, and there should be periodic follow up to see how the person is adjusting to medication and how the person is responding as well to the medication. So again, these are the summary of your management. Prop the patient up in cardiac position, give intranasal oxygen, give your diuretics, control the BP, then manage other risk factors such as the diabetes and so on. Then encourage the person to stop smoking, reduce alcohol intake, regular exercise, and diet therapy. So these are what your management for this patient. All right. So you are to do a lumbar puncture, okay, like we did in the first question when we talk about what the meningitis, isn't it? So you have to do a lumbar puncture on a man who is suspected to have meningitis. Now you see. Now lumbar punctures have both diagnostic and therapeutic indication. Of course, it has both diagnostic and therapeutic indication. What I mean by diagnostic is it is used to diagnose. Just like in the case of meningitis, you want to make a diagnosis. So you have to use it so you can tell if there's something in the CSF or the cerebrospinal fluid, to check if there's blood, to check if there's increase in cells. That is more or less like what diagnostic. Then therapeutic is like you are using as a procedure to give medication or for treatment. So that is what we are going to be discussing right now. So lumbar puncture has both diagnostic and therapeutic indications. So let's look at the question that follows. Now, list 3 diagnostic indications. 3 diagnoses. That means on one condition, are we going to use lumbar puncture as or for diagnostic purposes? For diagnostic purposes. So over here, what can you be looking out for? If the person is having what? Neck stiffness or signs and symptoms of meningism, you might want to use lumbar puncture as a diagnostic indicator. Because neck stiffness could be meningitis, encephalitis, isn't it? Now you can also talk about altered consciousness. Altered consciousness. For example, in the case of subarachnoid hemorrhage, somebody could lose consciousness. And you have to do lumbar puncture to make sure that there's no blood in the CSF. If there's blood in the CSF, that could confirm that this person is having subarachnoid hemorrhage. Then when you're having an unexplained fever, or fever of no origin, you might want to consider doing a lumbar puncture. Then, of course, unexplained seizures or unexplained convulsion, you might want to consider doing a lumbar puncture as well. So again, signs of meningism, you have to do lumbar puncture. Altered consciousness, unexplained fever, unexplained seizure, unexplained convulsion. They are all the same. So these are the things that perhaps we can use lumbar puncture for. Now, list 3 therapeutic indications. So what do we use it for? What kind of medication do we use it for? So basically, we use it in a spinal anesthesia. Spinal anesthesia, that is injection of a local anesthetic or an opioid into the subarachnoid space. So basically, spinal anesthesia. Then you can also give it for intrathecal administration of chemotherapy. intrathecal administration of chemotherapy. That's like an injection into the spinal canal or into the subarachnoid space for chemotherapy. All right. We're going to talk about intrathecal administration of antibiotics. Antibiotics. Again, there's an injection into the spinal canal. So you're injecting antibiotics into the spinal canal or into the subarachnoid space. Then last but not the least, you can talk of injection of contrast media for myelography or for cysternography. Injection of contrast media for myelography or for cysternography. So these are some of the therapeutic indications or medicinal uses for lumbar puncture. Again, spinal anesthesia, intrathecal administration of chemotherapy, intrathecal administration of antibiotics, injection of contrast media. So these are the therapeutic indicators or indications. What are the contraindications? In other words, under what condition are you not going to do lumbar puncture? Under what conditions? One, when there is an infection at the lumbar puncture site. So you want to do lumbar puncture, usually around the L3 and the L4, the space between the L3 and the L4. That is where we do the lumbar puncture. Okay. So now if there is any source of infection or there is sort of infection around that area, it is contraindicated for you to do lumbar puncture. Then when you are suspecting an increase in intracranial pressure, don't do lumbar puncture. Then in cases of severe thrombocytopenia, don't do it. Then when you're also suspecting cord compression, these things you wouldn't do lumbar puncture. Again, infections at the lumbar puncture site, suspected cases of raised intracranial pressure, severe thrombocytopenia, suspected cord compression. So these are the contraindicators. What are the complications of the procedure? So now we are not talking about contraindications. We are looking out for what? Complications. So you are finished doing lumbar puncture. What can it lead to? What are some of the consequences we can find? The complication. One, you can talk about the post-lumbar puncture headache. So sometimes when you finish lumbar puncture, you will have what? Headache. You can talk of infection. You can talk of bleeding. You can talk of cerebral herniation. Then you can even be considering some minor neurologic symptoms. Basically, you can be looking at some of these things as the possible complications of the procedure. All right. So again, headache, infection, bleeding, cerebral herniation, and minor neurologic symptoms. All right. So a middle-aged man reported to you with an unexplained weight loss, for 4 good months. He feels better when the room temperature is low, guys. When the room temperature is low. You know, people who have low thyroxine level, they love low temperatures. So that could be a reason, because people with high thyroidism or high thyroxine, they are heat intolerant. Okay, they are heat intolerant. So they want things that are low. Sorry. So over here we're talking about hyperthyroidism. Sorry. So increased level of thyroxine. So they become heat intolerant. So they want cold weathers. So you defined. Now you notice fine distal tremors accompanied by an irregular pause. Again, there are what? Tremors. 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 Okay. So now let's look at the question that follows. List 3 conditions associated with weight loss. So under what conditions can we have weight loss? Now, let me try to classify them for you so that it will be easier for you to get them right. So we can consider what we call endocrine or metabolic conditions. Endocrine or metabolic conditions. Example, hyperthyroidism, type 1 diabetes mellitus, hypopituitarism, hypopituitary gland, pituitary gland function. Then anorexia nervosa. These are the people who, in their mind, they are fat, so they want to be slim. Anorexia nervosa, so they don't eat. They will not eat. Then we can talk about Addison's disease. Addison's disease. Addison's disease. That's to do with the adrenal gland. Addison's disease. So again, what are some of the endocrine or metabolic conditions that can lead to this condition or weight loss? Hyperthyroidism, type 1 diabetes, hypopituitarism, anorexia nervosa, Addison's disease. Addison's disease. All right. 5 causes of tremors. 5 causes. 5 causes. Guys, sorry. Before that, let me add GIT diseases or GIT. So let's go back. Let's talk about GIT disease that can also lead to weight loss. Celiac disease can lead to weight loss. Crohn's disease can lead to weight loss. Then peptic ulcer can also lead to what? Weight loss. Or ulcerative colitis can lead to weight loss. Let's talk about CNS disorders or brain disorders, CNS disorders. We can talk about depression, Parkinson's disease, dementia. Depression, Parkinson, dementia. These things can also lead to what? Unexplained or can lead to weight loss. Then other causes could be cancer, could be parasitic infection, drug abuse, side effect of some medications, alcohol abuse, etc., etc. That was just by the way. So out of these, just mention 3 and you're good to go. Now give 5 causes of tremors. 5 causes of tremors. Causes. So over here, you can think of what? Multiple sclerosis. You can think of stroke. You can think of brain injury or traumatic brain injury. You can think of Parkinson's disease. You can think of alcohol abuse or withdrawal. You can think of hyperthyroidism, mercury poisoning, liver or kidney failure, anxiety or panic disorder. Guys, there are enormous, a lot of them that can cause tremor. So just mention 5 out of the lot I've mentioned. Multiple sclerosis, stroke, traumatic brain injury, Parkinson's disease, alcohol abuse or withdrawal, mercury poisoning, hyperthyroidism, liver or kidney failure, anxiety or panic disorder. All right. Now, 3 eye signs associated with hyperthyroidism. Eye signs. Eye signs. So basically, you are going to be looking at what? Periorbital edema, periorbital edema, conjunctival edema, conjunctival edema, lid retraction, lid retraction. We can talk about lid lag, lid lag. Then exophthalmos, exophthalmos. Also, people can pronounce it as what? Proptosis, proptosis or exophthalmos. That's an abnormal protrusion or displacement of an eye, an abnormal protrusion. So, again, we have exophthalmos, lid lag, lid retraction, conjunctival edema, preorbital edema. These are the eye signs associated with hyperthyroidism. All right. Tests What test will you do to confirm, to perform in this patient? What test will you do to confirm in this patient? So definitely you are thinking of what? Hyperthyroidism, isn't it? So what you do is thyroid function test. Thyroid function test. You can also do glucose test. You can do ACTH test. ACTH test. You can do endoscopy. You can do biopsy. Again, thyroid function test, glucose test, ACTH test, endoscopy. Then you can talk of biopsy. But the most important one among all of them is the thyroid function test. So if they ask to mention just one important test to do, you are going to look at for what? Thyroid function test. But the question is specific on the number of answers to give. You can give as many as you can remember. All right. Okay. So we have a young girl with her mother who visited your facility with a progressive hair loss, okay, over her scalp, which started few days ago. A young girl, and then there's what? Alopecia, isn't it? Which started few days ago. So let's look at what the questions are. Common causes of alopecia in children. Common causes. So one, you can talk of tinea capitis. Most of us know it as the what? The ringworm infestation or the ringworm infection. Ringworm. So tinea capitis. You can talk about androgenetic alopecia. You can think of alopecia areata. You can think of traumatic alopecia or traction alopecia. If you want to talk about traction alopecia, we are referring to the kind of injuries lady inflict on themselves, especially when they go to do their braidings. I mean, hair braids or straightening of their hair. It can lead to what? Loss of hair from their head. Okay. Then the alopecia areata. Visually, this is an autoimmune disorder in which your body attacks your own hair follicles. So that is what? Alopecia areata. Then we have the androgenic alopecia. Usually this is what we normally call it bald or baldness. But I think in children, you can't find this kind of baldness in children, maybe. But definitely, moving forward, you might want to look at androgenic alopecia. Then you can also have alopecia as a result of chemotherapy. You know, those who have cancer, you either they have no hair, isn't it? That's because that type of hair loss, we call it telogen effluvium. The effluvium. The effluvium. Effluvium. Basically, these are things that you need to know. But there are some too, psychological in their brain. They are just born to steal, isn't it? They are born to steal. So we have another type for people who are just born to, or their hair is just removing just like that. Yeah, those people are also there. Or due to stress, due to anxiety, and things like that, they can also be considered. And sometimes we call them the trichotillomania. So they'll be there, they'll just be removing their hair as, I don't know, maybe stress, maybe anxiety. So they're just removing their hair. All right, so these are the basic, the cause of alopecia, basically. All right. Classify alopecia. Okay. Now, alopecia can be classified into two. We have the scarring and then the non-scarring. Now, when we talk about scarring, definitely, as the name implies, there's scarring at the end of the alopecia. You don't see any hair probably again, isn't it? So, there is fibrosis and permanent hair loss. fibrosis, and permanent hair loss. That is the scarring type of alopecia. Then we can talk about the non-scarring type of alopecia, whereby, of course, the hair can always what? Grow back or return. Hair can always return. All right. How will you treat hair loss? How will you treat hair loss? So basically, you can treat hair loss, topical and systemic immunomodulant or modulatory what? Agent. Immunomodulatory agent. So topical and systemic. Then you can do patient education, especially those suffering from traumatic alopecia, where they go and do their braidings, their hair, and at the end of the day, hair is being lost from their head. So they can be what? Some education. Then people with that kind of maniac problem or psychological problem, that's the trichotillomania people. What you can do is that you can give them the SSRI, that is selective serotonin reuptake inhibitors. You can recommend these kind of things for them. So all of these can help in the management or the treatment of alopecia. All right. All right. So thank you, ladies and gentlemen. I appreciate your time with me. But if you have any question, please feel free to write it in the comment section. If you have any addition, please contribute and let's make this place a better place. Let's make learning fun for everyone. All right. So see you in the next chapter or in the next tutorials. Bye for now.